Welcome, everybody. Good afternoon. It's great to see everybody here. For those who don't know me, I'm Sandro Galea. I have the privilege of serving as Dean of the School of Public Health. Welcome to our annual SHINE lecture. I wanted to formally thank the SHINE family for being with us and for endowing this lectureship. I'm going to let Professor Annis tell us a little bit more about that. But this for us is part of a series of really our highest profile dean level events at the school, where we really bring world-leading speakers and thought leaders to provoke us about some of the ideas that are really most at the forefront of the public conversation. And I think today we're going to have exactly a session like that. We have an outstanding speaker who, again, I'm going to let Professor Annis introduce, and I'm very much looking forward to this session. George.
One of the few deans I've ever met who can be short and sweet, and actually did that very well. You know, welcome everybody to the annual SHINE lecture, and I want to recognize and thank Ian Shine, Deborah Shine, and Thomas, who are here with us today on a lecture that memorializes Cathy Shine and her bad experiences with healthcare. Our speaker today is going to talk about other experiences with healthcare, not quite so bad, but bad in terms of insurance, underinsurance, and difficulties people have in actually accessing healthcare in an era where we're supposedly all covered with health insurance, right? Emily Friedman is an old friend. I've known her a long time. She's an independent health analyst and ethics analyst. She's written 6 books, hundreds of articles. Two of the weird things I never knew about her is she's an honorary member, lifetime member of the American Medical Association. How weird is that? And of the American Hospital Association. I didn't even know you could be those things. She has lots of experiences. Some and even more horrible things than I've been involved with. She's been chronicling the Cambodian attempt to build a healthcare system after the genocide for the last 10 years and spends a lot of time in Cambodia. She's also recently written a number of high-profile articles on the destruction of hospitals in war zones, but also she warns us they could be targets even outside of war zones. And that's very, very important work. She's also a poet and an expert on folk music and its preservation. She told me not to say she's an old-time hippie from Berkeley, so I won't say that. And most importantly, from my point of view, she's a human rights advocate, and I think can always be found on the side of patients when we're looking at patients in hospitals and doctors. Emily Friedman.
Good afternoon. Is the mic working? Everybody can hear me okay? Great. I want to thank you all for giving up your lunch hour to come to this talk. Giving up food to listen to a lecture is a rare sacrifice, and I do appreciate it. It is an extraordinary honor for me as just a run-of-the-mill policy wonk to give this address, and I want to thank Boston University School of Public Health for asking me to do so. I wish also to acknowledge the presence of Catherine Shine's parents, Ian and Deborah, Dean Galea of the school, and my many friends and colleagues, including George Annis, whose work partially inspired the creation of this lecture, and Alan Sager, there he is, who has advised me and kept me on the right path as much as that is possible with me for many years. Keeping me on the right path is, oh, thank you very much. Keeping me on the right path is a difficult task, but Alan has done his best. This lecture honors the memory of a young woman who should not have died, as well as her work as an advocate for patients' rights. And it also honors George Annis's tireless work in those same, sometimes thankless vineyards. Given the outbreak, if you will, of patients' rights activity, which I trace back, everybody's got a different date, which I trace back to the 1960s in terms of the publication by the Boston Women's Collective, I might add, of our bodies ourselves in 1969, and the work of Jay Katz, a great colleague of George's and Ellen's and many of the people in this room, and his exposure of the horrendous experiment at Tuskegee University, which was not only a violation of human rights, but also profoundly racist. Given that, I would have thought that we'd be further ahead than we are. But informed consent sometimes still remains only a theoretical concept. Many patients are mistreated, overtreated, or undertreated, often for financial reasons. Sometimes providers still try to talk them into services they don't need, an experience I have certainly had. I'll just tell you this. I've got a trick knee. It likes to dislocate when it feels like it. So I decided at one point maybe I'd try to do something about that. I got x-rays. I got a CT scan. I got an MRI. They couldn't find anything, so the orthopod said, well, I guess we're going to have to scope your knee. And I said, no. If you haven't found it with 3 tries, honey, you don't get a 4th shot at the apple. The malpractice litigation landscape remains a disaster. And most patients, no matter how educated or sophisticated, still have a habit of saying, whatever you think, doc. But has often been observed about healthcare costs, the situation is like a slightly underinflated air mattress. You push down on one, this is actually a metaphor I got from Ellen Sager. You push down on one part of it and another part puffs up. You just can't get a handle on it. So I'm here today to talk about some of the new puffs. With the passage of the Affordable Care Act, some parts of which I like and some parts of which I loathe, I was hoping, naive little character that I am, that the health insurers would get with the program and stop discriminating against people who are low income or sick or both. Well, guess again, Emily. I thought that they had a golden opportunity to move from risk aversion, that is, avoiding covering sick people, to risk management and shift to saving money by keeping well and coordinating care. Silly me. I do a lot of work internationally, and I have to tell you the most difficult question I am asked is generally, why don't your health insurance people actually insure sick people? And you don't have an answer for it. I mean, what are you going to say? Well, they don't want to. The insurance community, and this includes nonprofits, for-profits, and self-insured employers, apparently became so addicted to avoiding coverage for sick people that it can't change the business model. And I've talked with a lot of people about this. And I was talking with a friend and colleague who's one of the most respected policy wonks around, and who is also very conservative. He's an old friend, but we probably couldn't agree on what time it is. And and I said, this is ridiculous. This is ridiculous to have health insurers who don't want to insure health. And he said, well, the insurers know that they need to change, but they don't know how. Give me a break. I can barely operate a toaster, and if I can learn to cope with the latest dysfunctional iteration of Microsoft software, the insurers could get a clue as to how to change the business model and move to seeing that coverage for all is a benefit for them. What I can't get straight in my head is you've got 30 million new customers. Why don't you want them? I mean, if it were Macy's, they'd be jumping up and down for joy. Instead, we are being subjected to new and fascinating ways to make health insurance and care difficult to obtain. Affordable Care Act or no Affordable Care Act. There are a lot of approaches being used. I will only address 3 of them today. High deductible health plans, pharmaceutical formularies, and narrow networks. High deductible health plans have been around for quite a while. often described in what I consider to be the height of hypocrisy as consumer-directed health plans, which are about as consumer-directed as the Department of Defense. I'm sure most of the people in this room know that they are less expensive than plans that offer broader coverage, but the kicker is the patient gets to pay the deductible at the point of service, which is lovely if you make $17,000 a year and just got hit by a truck. The argument, using a phrase I detest, is that it is necessary that the patient have skin in the game, as though obtaining health care is equivalent to visiting a casino in Vegas. The idea is that they will become wiser shoppers. Well, there are only 4 problems with this approach. I'm sorry, I've got allergies, so from time to time the tissue has to come out. People who obtain coverage through their employers often have little or no choice of plan, and 52% of employers are now offering or requiring high deductible plans. I have a great deal of sympathy for the employers on this. Healthcare is an extremely expensive benefit to provide. And I live in Illinois, which now, you just gotta love the land of Lincoln. We now rank 50th out of 50 states in terms of not being able to fund pensions for retired public workers. And you don't even want to hear about Chicago. Well, you don't want to hear about Chicago anyway. I mean, Chicago's a sport. But we have a lot of employers who are now requiring high deductible plans. So employees now have skin in the game, whether they want to or not, and whether they can afford it or not. The numbers, for those of us who have not won the lottery recently, are a little scary. Approximately a quarter of the U.S. population has a deductible of $2,000 or more. 63% of workers in small firms and 39% of those in large firms have deductibles of more than $1,000. Given that nearly 2/3 of Americans have less than $1,000 in savings, that ain't going to work out too well. Now, as John Kingsdale, who was here and who was one of the architects of the Massachusetts health plan, pointed out to me earlier today, the Affordable Care Act, if you buy on an exchange and get a subsidy, there are protections against this. But for people who aren't buying on the exchanges, for people who are in the individual market, for people who get coverage through their employer, they're stuck with these deductibles. And there's also the notch group, especially if you live in a state like, say, Texas, where Medicaid, you have to be dead broke to qualify for Medicaid. And so there's what we call the notch group, which is people between those who are eligible for Medicaid and those who can afford any kind of private insurance. And they're stuck too. And high deductible health plans are often all they can afford. The second problem with this type of coverage is that healthcare providers, some of whom can afford it and some of whom cannot, end up serving essentially as secondary insurers because they are forced to eat the costs of the unpaid deductibles. I was talking with a sister who runs a Catholic health system in another state. Well, it's actually in 5 states. And I said, so how are you doing on bad debt? She said, better in some ways, not so good in others. I said, what percentage of your bad debt, of the money that you're actually losing, is unpaid deductibles? And she said, 40%. Craig Becker, who runs the Tennessee Hospital Association, says that hospitals are now the second largest insurers in the state of Tennessee, simply because of unpaid deductibles and copays. More than half of hospital bills in this country do not get paid in full or at all. Hospital and physician responses range from just eating the costs to using bill collectors. As the administrator of a hospital in Childress, Texas, recently told a reporter, it feels like a sucker punch. And the truer words are never spoken here. When someone has a really high deductible, they're still uninsured. And most people in Childress don't have $5,000 lying around to pay their bills. As for the Affordable Care Act, between 60 and 70% of enrollees choose silver plans. That's the second highest level. And a lot of them have quite hefty deductibles. For those whose care is subsidized by the feds, the percentage is even higher, around 77%. Again, they are protected against outrageous deductibles, but I don't see this boat balancing itself anytime soon. And given the constant drumbeat to repeal the ACA, we could be in one heck of a mess if something happens to the law. The third problem with high deductible health plans, and this is just one of my pet peeves, people don't know what they're buying. The ACA is an impossibly complex law. The implementation of it has been incompetent at times. The states are all over the place in terms of who's running the exchange, Medicaid expansion and regulation. And maybe somebody knows what's going on, but it certainly isn't me, and I do that for a living. I would be glad to give you a long dissertation on the Affordable Care Act and what's wrong with it. It has some very good provisions in it. I'm glad it passed. But boy, it's not the law I would have written. But the fact is, it's not transparent. And on top of that, the Obama administration, the states, and the insurers have done an absolutely abysmal job of explaining this law to the people who are supposed to benefit from it. And the thing is so labyrinthine that you would have better luck comprehending technical concepts of astrophysics. And part of that is intentional, and that, again, is why this is one of my pet peeves. Some of the states that expanded Medicaid for political reasons don't really want people to sign up for Medicaid. The insurers don't want to cover sick people, and with this administration coming to an end, most of the feds are out looking for new jobs anyway, so nobody's running the store. The ACA has limits on cost sharing by patients, but they vary by plan and by how much health care you use. And these limits have only recently kicked in. We're just going to have to see how that goes. The fourth problem, and this is extremely serious, and it may be the worst of all of these problems. People are going without care because they can't afford the copays. A study just came out, thank you, Wendy. In Massachusetts, more than 1/3 of adults younger than 65 reported going without needed care. 20% reported having trouble paying bills. 37% of people aged 19 to 64 forego care because they cannot afford the copays. This is Massachusetts. Can you imagine what's going on in Texas or Louisiana or Alabama or Florida? And one of the worst areas, I just was reading an article about this, one of the worst areas is they're foregoing prevention. If you're under 65, Medicare mandates prevention without copays, but a lot of these plans don't. So we've got women going without mammograms, we've got men going without prostate exams, and I've lost 2 friends to prostate cancer, so I take this very seriously. They're not getting moles checked, they're dying of melanoma, and people are dying of preventable, treatable disease because they are supposed to have insurance. They're counted as insured. All the statistics, oh yeah, you know, we have 30 million more insured people now. But they aren't going for care because they can't afford it. And if you don't think there's a human price to pay for this, think again. Probably a few people in this room have heard of Rex Iverson of Bear River, Utah. But on January 23rd, he was arrested for failure to pay an ambulance bill and thrown into the county jail where he died. There's a human price to this. There's a human price to this. The second form of consumer-directed abuse of patients is pharmaceutical prices, on which I need not dwell very long because the issue is all over the news and most of the people in this room are well aware of it. I'll just highlight a couple of issues. The pharma companies say that it's dreadfully expensive to develop drugs and most of them don't work and they fail in clinical trials, and so they have to charge a lot for those that do make the grade. We won't discuss the side effects of those that turn out to be dangerous and are taken off the market after they're released. But the companies fail to mention that a large percentage, and I mean a large percentage, of pharmaceutical research is funded by the feds or private foundations. The National Institutes of Health, the Hughes Foundation, a number of other private foundations. The pharmaceutical companies are not paying for all of their own research. That's just a fib. Pharma is lucrative for one reason, and that is that pharmaceutical prices are not regulated in this country. You know, if you talk to the Shines, you know, Britain doesn't allow it. If there are any Canadians here, Canada doesn't allow it. Nobody allows it except us, because the market's going to take care of it. Well, listen, I am all for market competition. I, honest to God, do believe that competition can lower prices and foster innovation, and I'm very serious about that. I mean, I live in a capitalist country. I was raised in a capitalist country, and I believe in competition. But it's hard to have competition when you've got one drug to treat a particular disease and nobody else makes it. That sort of puts a little bit of a damper on the effect of competition. And so it's difficult to use competitive forces to monitor drug prices. And because we won't regulate them, we end up with these ludicrous situations like this 32-year-old entrepreneur who bought a 75-year-old drug and raised the price by 5,000% earlier this year. I don't know of any other country, and like I said, I go overseas a lot. I don't know of any other country that would have allowed such a thing. And this is not to mention the repeated scandals in which it has been discovered that pharmaceutical manufacturers were bribing competitors to keep them from producing generics after the patents expired. Or when your patent is about to expire, you change one molecule in the drug and then you get another new, fresh patent. There are an awful lot of games that get played. The second issue, in keeping with the topic of this talk, and this is infuriating, is that the insurers have found a new and exciting way to avoid insuring sick people, and that is manipulating pharmaceutical formularies. Now, this is a little wonky, and I'm sorry, but after all, we're a school of public health here, so forgive me for getting wonky for a minute, but any insurance plan has tiers. Well, both kinds of tiers, but in this case I'm talking about TIERS. And a drug can be in the first tier, the second tier, the third tier, sometimes the fourth tier. And there's different copay requirements for those tiers. So if you're buying a generic laxative, you know, you'll pay 59 cents as a copay. But what the insurers figured out is, because they can arrange cost sharing as they wish, there are copays as high as 40% for a lot of pharmaceuticals, and for some funny reason, medications for conditions like multiple sclerosis, Parkinson's, cancer, AIDS, and other expensive diseases all end up in the top tier with massive cost sharing. Imagine that. I have a friend who has an extremely rare condition. I'll tell you how rare it is. There are 8,000 people in the United States who have this. And a medication came on the market just in time when she was dying. And she's alive and well and thriving. But the drug costs $110,000 a year. And you have to sort of ask if that type of pricing is necessary. But the manufacturer can get away with it because it's an orphan drug, a concept I'm sure you are all familiar with, which is, it's a drug for any condition that less than 100,000 people have. And if it's used by very few people, there are special exceptions in terms of pricing, patents, and so forth. And the pharmaceutical companies have learned to manipulate orphan drug provisions very adeptly. The third coverage problem, which has only surfaced recently, is narrow networks. Now, this concept has been around for a while because some of you may have experienced it, and that is that your health plan can drop your physician anytime it feels like it. There's been litigation over this, especially in California, but now it is almost becoming a norm. A person signs up for a health plan, usually without sufficient information about the plan, of course, because you can't figure out what the plan's about or what it covers or anything else. And some people don't do their homework, but most of us just can't go through all of what is essentially the red tape on the fine print to figure out if this is the right plan for you. And then the person finds out that the hospital she's been using for years or the physician she has been with for years are not included in the plan. And then she faces a really yummy choice. She can stay with her chosen providers and pay what are quaintly called out-of-network costs, which can be tens of thousands of dollars. Or you can totally rearrange how and where you get your health care, and particularly for people who have chronic conditions, people who have Parkinson's, people who have asthma, people who have MS. Turning everything upside down when your providers know what's going on with you is a terrible idea, if nothing else, in terms of quality of care. And believe me, I'm sorry to say this, I know this is a very cynical talk, but what the heck, you know? I've been influenced by Georgiana's, what can I say? And believe me, this narrow network business is rarely based on outcomes of quality of care. It's all about money. What they're trying to do is dump the academic medical centers. But I'm going to give you two examples which should scare you. I hope they do, because they sure scared me. Many of the health plans in the Pacific Northwest decided to exclude Seattle Children's Hospital, which is the finest pediatric institution in the Pacific Northwest, from their networks. But I was just down speaking in Houston. Most of the health plans in Houston decided to exclude MD Anderson Hospital, one of the 2 or 3 finest cancer treatment centers in the United States, from their networks. And there are other examples. Now, you all work and live in the most expensive healthcare market in the country. And I think it can only be expected that the general, the deaconess, I don't think they could pull it with Boston Medical. I don't think they could get away with it. But some of the hospitals that you all use and that some of you work at could be excluded in the future. And you really have to fight. Seattle Children's had to go to court. MD Anderson remains excluded, so if you've got cancer and you're in Houston, you're going to have to hit the Mayo or Sloan Kettering or some other place, or you get to pay out-of-pocket cost. I think it is, if it were based on quality, are there healthcare providers I wouldn't go to if I had a gun at my head? You bet there are. But I don't think that's what this is about. And everything I have read, everything I have seen, I mean, I just read an article yesterday when someone from Gorman and Associates, and those guys know what they're talking about, said in 5 years, everybody's going to be in a narrow network. And the question is, will your physician be in it? Will your community health center be in it? Will your hospital be in it? And what are you going to do if it isn't? A long time ago, James Talon, who runs the United Hospital Fund of New York, told me something. He's the former majority leader of the New York State Legislature, and one of the finest health policy minds in the world. And he said, Emily, I'll tell you one thing. Don't take anything away from people that they think is their right. And I think we're going to have a war over these narrow networks. We've just had skirmishes so far, but I think we're going to have a war. And Medicare does not allow this sort of thing. I mean, unless you join Medicare Advantage. And anyone who joins Medicare Advantage, there's this bridge in Brooklyn I'd be glad to sell you really cheap, you know. But if you're not Medicare eligible, or you're in Medicaid where you don't really have a choice, most Medicaid patients are now in managed care plans. There are a lot of dangers out there where people simply can't get the best care. People can't get the best care. And meanwhile, of course, the providers have to make all these sacrifices in order to stay in the network. So what might be done? I have 5 suggestions, not that anyone in power is going to pay any attention to them, and then I hope we can have a lively discussion in the time we have left. The first is establish reasonable limits on patient cost sharing. You want to base it on income, fine, but make it reasonable. $12,500, and by the way, that has a real deductible that a woman, I think in Vermont, was stuck with, of $12,500 is not a reasonable deductible. For all intents and purposes, she's uninsured, and she's got kids. So establish reasonable limits on patient cost sharing, and you want to scale it by income, fine, but do something about this. Second, which I've been advocating for 20 years, not that anybody's ever listened, establish a universal benefit package to which all insurers and employers, public and private, must adhere. What we have right now is the silly arrangement with 53 different Medicaid plans, and they've all got a different benefit package. Every single insurer has a different benefit package. Medicare Advantage plans all have different packages. The only thing that's consistent is Medicare, but you have to be 65 or disabled to get onto the program. And I simply don't understand why we can't establish a floor below which no one is allowed to fall. I mean, they did a little interview with me that some of you may have seen in preparation for this talk. I don't care about ceilings anymore. Bill Gates is going to be able to get whatever he wants from the healthcare system because he's got an unlimited amount of money. Steve Jobs, poor man, I'm sorry he died, but he went out and bought himself a liver. I'm worried about people who don't have much choice or much money. And I think we have to establish a floor so that everyone at least gets that much care and that much access and can afford it. My third suggestion is ensure transparency in terms of health plans so that people at least have a ghost of a chance of understanding the plan they're selecting. Right now, it's a black box. It's just a black box. You don't know what you're getting. Most people say, oh, Blue Cross and Blue Shield, yeah, they're good, I'll get them. And then you end up in a situation where you're stuck with it because the open enrollment period isn't for another 9 months. And that's even true of Medicare. And if you don't like your insurer, or they drop your hospital, or they drop your doctor, or as what happened with me, my Blue Cross and Blue Shield premium went up by 35%. There was nothing I could do. Nothing I could do. And, the insurers have got their issues, too, because especially with Medicare Part D, for example, they have to carry these ridiculous drug prices. So you can understand how those premiums could go up. But it would help, by the way, just as a side note, that Medicare Part D should allow Medicare to negotiate for lower drug prices because it is prohibited from doing so by law, and that's disgraceful. So, speaking of which, place some limits on pharmaceutical pricing, or at the very least inform the public as to who is paying for the development of medications, because maybe they'll get mad enough to demand change. Because so far everybody is buying the pharmaceutical argument as, oh, well, we have to spend all this money on R&D. Yeah, really? And what's the National Institutes of Health, chopped liver? The amount of outside funding that they get is enormous, and we need to have more public awareness of that. And fortunately, this is going to happen in the near future because this narrow networks thing is really starting to irritate people. So both the feds and the states are working on making sure that networks are adequate and that you don't exclude MD Anderson for cancer patients. But make sure that provider networks are adequate and that some of our finest hospitals, group practices, and physicians are not excluded. And if you're going to have a narrow network, I've got an idea. Why don't you base it on outcomes and quality? You know, instead of cost, instead of how do we save money? Well, to close up here, this lecture was established in honor of two people, Catherine Schein, who was terrorized by our healthcare system to the point of death, and George Annis, who has worked all his professional life to protect the rights of patients. And I will say, in closing, that I believe that one of the core rights of a patient or potential patient is to have reasonable, affordable coverage and access, and to say that someone has coverage when she's facing a $12,500 deductible does not meet that criterion. Mother Teresa once said, if we have no peace, it's because we have forgotten that we belong to each other. If we cannot achieve that sense of belonging in healthcare, we are not going to achieve it at all in this society. So let us work to create a healthcare system in which we belong to each other, all of us. Thank you very much. I'm going to sit down because I just got back from Cambodia where I managed to, it was a very exotic injury. I slipped on the bathroom rug in my hotel room and hit my leg on the bathtub. Yes, sir.
Yeah, I wonder if you would comment on what I think is the elephant in the room of solutions, which is single-payer Medicare for all, everyone in, no one out. I would like to just plug Physicians for a National Health Program if people don't know about it. We've been working on this for 27 years now.
And here's to the memory of Ron Anderson.
Thank you.
And also of Quentin David Young. And
yes.
For those of you who were not familiar with Quentin Young, he was my doctor, he was President Obama's doctor, he was Dr. Martin Luther King's doctor. I don't even know how the guy made a living. I never saw him charge anybody. And he helped found Physicians for a National Health Program. He died last week.
So I'll just say we have 20,000 physician and medical student members nationally. I have some brochures here. I'll leave them by the door. I encourage everyone to sign up or at least go to our website, pnhp.org, to find out more about this movement. Thank you.
Well, and I'll give you my opinion on this for what it's worth. If I could solve my problem with Congress having control of the entire healthcare budget, there might be a time when I could go with Medicare for all. But I have seen too many instances where a pot of money has been piled up for healthcare, one under a Democratic administration in Florida, one under a Republican administration in New York State, and in a third case in Arizona, although that was for Medicaid. And in all three cases, the legislature hijacked the money. And if we could protect the pool of money, but I have to tell you, and it's not because of this particular Congress, it's Congress in general. Wouldn't care if they were both Democratic houses at this point. I am just concerned that the money would go bye-bye and turn into fighter jets or highways or stadiums or something. But I certainly, Ron Anderson was my friend, and Quen Young was a friend for decades. And Quen always told me that that was the one argument he couldn't solve. All the other arguments you can address. So I think one of the things that PNHP should do is figure out a way where the money could be protected, because I just don't see handing $3 trillion to the Congress of the United States and say, make sure you spend this wisely. And I'm not saying that as anti-government, it's just, I've just seen money get hijacked too often. Yeah, where's the mic?
I want to thank you personally, because I feel like the story spoke to me on a personal level. My mom is a senior, and I was actually on the phone with her on my way over, and she's worried that she's going to reach the donut hole by June because her cost sharing on one medication is $100. But I'm also thinking of my dad, who passed away in June of 2014 and very unexpectedly acquired a disease that required him to have long-term care. And I'm wondering if you could speak to what I think is the injustice of long-term care and talk about variety. Welcome to spin the wheel of 50 states and try to move somewhere else so to work out better for you. That is just basically bankrupting families and bankrupting what they've worked for and putting them in the position of living in a financially disastrous life versus getting the care that they need for their loved one.
And it's an extraordinarily important question. I can give you one piece of good news, and that is the donut hole, thanks to the Affordable Care Act, is going away. It'll be a few years, but the donut hole is shrinking. I don't know of any healthcare system that is taking long-term care seriously. I can give you the historical basis for it. People didn't used to live this long. 100 years ago, life expectancy in the United States was 47. So nobody thought about it. So the healthcare system, it's the payment system, the whole banana grew up focused on acute. And so now long-term care, assisted living, helping people stay in their homes is considered very unsexy. But part of it is, and again, this is my cynicism coming forward, figure out a way to pay for it other than Medicaid or personal finances. I don't brag on myself often, but I'm pretty expert on the Medicaid program. And if you read Public Law 8997, which created Medicaid, it's Title 19 of that law, there's just this one little provision that says, oh yeah, and we'll pay for a little long-term care. But Medicaid wasn't designed for that. Medicaid was designed for care of low-income and disabled people. And now the bulk of Medicaid's expenditures are on older people with long-term care needs. And long-term care insurance is shabby, skimpy, and extremely expensive. And many long-term care providers, most of them are for-profit, and they don't want insurance. They want cash on the barrelhead. And as we get older, the average life expectancy for an American woman is heading toward 85. A white American woman, excuse me. And we're still ignoring the issue. And until such time as we understand that chronic disease costs are going to outrace acute care costs, whether it's diabetes, whether it's paralytic disease, MS, Parkinson's, dementia, which is really a huge issue. Injuries from falls, traumatic brain injury. All of our young folks who are coming back from Afghanistan and Iraq with TBI, traumatic brain injury, are going to need to be monitored for the rest of their lives. And a lot of them are likely to end up with premature dementia. I mean, a friend of mine, a really good friend, just died of early onset Alzheimer's at the age of 52. We do have to get serious about it, but you're going to have to find a way to make it financially attractive. Alan, I'm going to put you on the spot. What do you think?
Thank you. When we're spending so much on acute care, it's hard to find the money for long-term, but there have been efforts to try to pool long-term and acute care money in the dual eligible demonstrations, the OneCare programs. But it's entirely possible that there will never be enough money for long-term care, because when you need long-term care, you need so much time from another person to do the things you can no longer do for yourself. Just imagine if you couldn't, tomorrow morning, if you woke up and couldn't manage, how much, you couldn't get out of bed, how much help would you need from another person?
Well, I have days like that anyway, but.
So we may need to devise new social arrangements that allow people to help one another when they can. A parallel economy of good deeds.
New York State has established something which I think should be a model. I mean, there's a lot of creativity that can be employed. But New York State started buying these multi-unit buildings, and people who could do some activities of daily living, but not all, would move into them. So they all have their own apartments, but they would eat communally. And then one nurse or one aide lives in the building. That's the kind of thing we're going to have to start wrapping our heads around, because people who are in nursing homes are very, very sick. And there is a need for nursing homes. I mean, I've got a friend who's on dialysis and has about 5 other conditions, and he finally had to give up and moved into a nursing home. And fortunately, it's only like 200 feet from where I live, so I can go visit. But most people don't have to be in nursing homes. And there are ways to arrange assisted living so that it's affordable. But we have to care about it first. And I think that just goes back to your question. It's not sexy, it's not well remunerated. And who cares about old people with Parkinson's? So you really need a cultural change on that one. I think it will come, because I know how rapidly this society is aging. I teach demographics on the side. And as I always say, I use the old joke, to a man with a hammer, everything looks like a nail. The demographics are going to determine everything. And when the average age in the United States is 60, then we're going to start taking this seriously. In the meantime, unfortunately, we're just going to have to putter along. And the states are suffering with this because it's breaking their Medicaid programs. So they've set up something, I don't even know how I feel about it, called asset recovery, which is once the person dies, they can go after that person's assets to recover what the Medicaid program spent on them. And I'm thinking, excuse me, what are our tax monies going to Medicaid for if that's what you're going to do? But on the other hand, I know, when he was, Tom, whatever his name was, he was mayor of New Jersey at one time, he said Medicaid is the Pac-Man of state budgets. It just eats up everything else. So we need to find a way to have private, or at least more broadly based, public funding of long-term care. And I'm very sorry about your family's situation. I have always considered myself fortunate that I was a late baby. So both of my parents died when I was, well, my mother died when I was 12, but they were able to get along by themselves. But it's rough, and I worry about myself. I mean, I'm the clumsiest human being on the face of the planet. That's why I'm sitting down, you know, because I can't walk on a bath rug at a hotel room in Phnom Penh without falling. And something could happen to me, and I live alone. I got no kids, no spouse. Any other thoughts? We've got maybe 4 minutes. Michael.
Insofar as health is what we're interested in, health is what we're interested in. We know that healthcare contributes a small amount to overall health. And so I was wondering if you could comment on something even less glamorous than long-term care, which is public health. Considering prevention is certainly something that's not glamorous, but is the fundamental basis for our health. If we can comment on funding and how things look for public health.
I finally got mad in terms of neglect of public health, and so I've got an article coming out on April 5th, and it'll be on my website. My website, by the way, is just my name, emilyfriedman.com, and I hold copyright on all my stuff. Steal it, download it, share it with your friends, you know, use it in the bathroom, whatever. Michael, I share your concerns. And when you look at what our public health folks do you know that the CDC just came up with an easy-to-use test for the Zika virus? It's been like 3 months since that virus emerged in the United States, and they've already got an easy-to-use test for it. Our public health, this is in my article that's coming out. A friend of mine, unfortunately, who has since passed away, who was deputy director of a public health department in a major American city, he did not want AIDS to become the disaster that it already was in Los Angeles and San Francisco and New York. He went out with the cops one night and closed all the gay bathhouses. It was completely illegal. You know, he had no right to do it. But the rate of AIDS in his city went down. I mean, it was much lower than in other places. I had the privilege of addressing the Association of State Public Health Officers once. And the first, you know, and then somebody asked a question like, you know, well, how do we improve public appreciation of our state public health departments? And I said, well, first you have to inform the public that you have a state public health department. The lack of visibility is a problem. You can't prove a negative. If you look at Jim or the Dean or George or the Shines, they don't have measles. That's not going to get you on the 6 o'clock news. And so our public health department's working very quietly to prevent people from being poisoned and stopping epidemics and doing the amazing work that they do, are underfunded, underappreciated, and understaffed. I wrote this article because I wanted to try to get some visibility for it. I think the American Public Health Association could do more to try to raise visibility. But I don't mean to be insulting, but in writing this article, I called the Surgeon General's office, the Surgeon General of the United States, and said, hi, could I get a comment for my article on the importance of public health? And they hung me up for 3 days, and then they declined to comment. The APHA never got back to me at all. I think public health has been so beaten down that it's hard for them, you know, to get up and say, hey, you know, we're essential. So am I optimistic? Not particularly. But the way it works is Zika virus shows up, Ebola shows up, somebody goes to the deli across the street, has a salami sandwich, and gets sick, and everybody goes, where's the public health department? And I think you have to take advantage. This is a school of public health. Every possibility for visibility, you have to take advantage of. You have to take advantage of the fact that public health is one of the most essential jobs in government. And we have to be more supportive, but public health also has to stand up for itself more. But it's the first thing to get cut, and it's a very difficult area to work in. The people who work in public health have my total support and appreciation. But I can't say that I'm optimistic that this is going to turn around. Jim.
Thanks, Emily. Probably, to be fair, I should disclose to people what I do for a living. So my name's Jim Roosevelt. I am the former CEO of Tufts Health Plan, which is one of the 3 largest health plans in Massachusetts. Massachusetts is organized differently for health insurance than the rest of the country. 90% of people in Massachusetts who do not have government coverage, and some who do, get their coverage from a nonprofit health plan. The national for-profit companies only insure 10% of the people in Massachusetts. Much of what Emily has had to say, well, first of all, things like deductibles, I completely agree with her on. It's a gross tool that, yeah, it lowers premiums, but it's the old Midas muffler thing, pay me now or pay me later.
Pay now or pay later.
Right.
Absolutely.
But the problems with formularies and the problems with narrow networks, by the way, Boston Medical Center will not be excluded from narrow networks. Why? Because it's lower priced than other academic hospitals. Those exist, and they can be done in a reasonable fashion for what they are, but they exist for the same reason that all these other tactics exist, which is the underlying high cost of healthcare in the United States. And it's an overall high cost. It's a higher overall cost in Massachusetts.
Right,
but it's
this
also,
market is ridiculous. I mean,
but it's also a very,
it is.
It's also a very, it is the cost of healthcare, the prices that are paid for healthcare are the least regulated part of the healthcare system. Mm-hmm. You might think insurance needs more regulation. In some ways it does, in some ways it doesn't, but it's the most regulated part of the system. The price paid to providers, physicians, and hospitals is the least regulated part of the healthcare system. And it's wildly unpredictable. My greatest claim to fame is my daughter, who is the youngest division director at the State Department of Public Health here in Massachusetts. And when she had her second baby recently, she had had her baby at Mount Auburn, which is a Harvard community teaching hospital. Cost roughly $7,500. She could have gone to Mass General for exactly the same care for $27,000, or to the Brigham for $30,000 for exactly the same care. Unless we start looking at the prices that we're paying and the underlying cost, we're not going to deal with all these other annoyances. We can have, Affordable Care Act says all preventive care has to be without deductibles or copays, for example. But then, when they find a mole that needs care, that's not preventive anymore. That's treatment. So we're not going to get anywhere on all of this until we get to the underlying cost. And to show you how controversial this is, I wrote an article about 3 or 4 months ago for the Boston Business Journal on pharmaceutical prices. And I talked about how there needed to be more transparency. We need to know what the research actually costs. We need to know how much goes to marketing and how much goes to profit and how much goes to actual production of the drugs. And right at the end I said that if transparency regulation or market forces can't deal with this, we might have to go to regulated prices like the rest of the world. The headline the Boston Business Journal put on it was, "Healthcare CEO advocates price regulation for drugs." Within 24 hours, I got a call from the National Association that represents health plans all over the country, AHIP, who said,
yeah.
"What are you saying? You're for regulation?" And I said, "Read the article. Don't just read the headline." So that's... comment I wanted.
Well, I think you've raised a great point, Jim, and I do think there's an issue here, and again, it was in that little interview I did prepare, before this talk, that was in Boston University today. One of the problems is we don't know what healthcare costs. I mean, that's the, there are all the jokes, there are all the jokes about the $10 aspirins and all of that, but the fact is, in a lot of cases, we really don't know what the cost is. We know what the price is, we know what they're trying to bill for, and you as a former insurance executive know darn well that the providers try to do whatever the market will bear because they're only going to get a percentage of what is being asked anyway. I mean, Cross and Shield in Illinois love to send me this is not a bill. Your doctor charged us $3,500. We paid him $1.29. So the providers are going to ask whatever they can. But if we're going to have a cost-based system, we've got to figure out some way to find out what healthcare costs, and it's not easy. A hospital is probably the most complicated entity you could possibly encounter, and you've got workforce costs and pharmaceuticals and 24/7 and emergency department and bedding and linens and uniforms and I don't understand why anybody would become a hospital administrator. I think they're all crazy. But if we can't get to cost, then we can't get to reasonable pricing. And if we can't get to reasonable pricing, then this is just going to go on.
So Emily, your last comment prompts another comment, which is we actually can get to prices pretty readily. We are well advanced technically from where we were 30 or 40 years ago when a bunch of states tried to regulate hospital costs, and we hadn't invented DRGs yet as a way of classifying outputs of hospitals. And we didn't have RBRVS as a way of allocating dollars to physicians. And we didn't have primarily capitation, which in Massachusetts is growing and growing.
Well, I'm a big
question
capitation
is,
fan anyway. So.
why wouldn't we capitate Partners or Children's or Mount Auburn or BMC, and why wouldn't we pay them DRGs at the same rate? Technically, that's quite easy to do. It's the political will to do it that isn't there, not the transparency of pricing or the technical issues of rate regulation.
Well, John, I think you're absolutely right. I would have three silly things that I believe in. Don't throw anything, guys. I'm not wearing red, so, well, I am sort of wearing red, but don't throw any tomatoes. You'll mess up my beautiful suit. I think integrated, and I mean truly integrated, I'm not talking about affordable care organizations or these pseudo outfits. I'm talking about Kaiser Permanente, Mayo Clinic, Geisinger, Virginia, Mason. Truly, thoroughly integrated organizations with salaried physicians have been proven to have better outcomes, to largely be cheaper, and to be much more innovative than the fragmentation that we have. So I believe very strongly in integrated multi-specialty based organizations. In any case, I believe that physicians should be on salary. Take the darn financial incentives away. Medicare concierge practices. I mean, give me a break. Oh, well, I'll give you my cell phone number if you pay me $2,500. And I say, I'll give you my cell phone number if you pay me $2,500. My second thought is I just believe in capitation. I always have. Not necessarily for the same reasons that you do, but you can move the money around the system. Kaiser Permanente is fantastic at that. And they get a lot of capitation, and then if Ebola breaks out or there's a bus crash or something, they can move the money around the system. And with capitation, you also know how much money you're going to get. And the third thing is, I do believe in having a pluralistic system. But I don't think, and I'm not trying to insult you, Jim, in any way, shape, or form, because there are provider executives with the same issue. But I don't think somebody should get $300 million, or in one case, $1 billion for converting a plan from nonprofit to for-profit status. And the fourth issue to that is, all the entrepreneurs in the audience are going to hate me. I think healthcare is a public good and a human service, and I think everything involved in healthcare should be nonprofit.